Thank you, sir, for this opportunity. So I'll be focusing on how do we deliver safe surgery, more specific to cataract. I have no financial disclosures uh, to share. So we have spoken about the quality pyramid, and the safety is the most important, being in the base of the pyramid, which means trying to do no harm to the patient. So the whole goal is you want to help the patient have better outcome. So this is a very good publication looking at about 3.2 million surgeries published in JAMA, looked at surgeries done over 8 years. This is all different specialties in a veterans hospital. And here they reported that there were about 277 errors, and these included wrong side or wrong site or wrong implants. This is all different avenues of medicine. And of these, the top on the list was ophthalmology. So in ophthalmology, we have the highest risk of having surgery on a wrong patient or the wrong eye or the wrong power. This is also because of the laterality issue. And while it is about 1 in 20,000 procedures, in the rest of medicine, it's about 1 in 10,000 in ophthalmology. And the most common reason which has been mentioned is that there is issues in performing a comprehensive timeout. You must have, some of you may have read the book by Atul Gawande on Checklist Manifesto, where now it has become mandatory from the WHO that we administer a surgical safety checklist for all our patients, irrespective of whether it's a procedure or a surgery. And this has proven to be beneficial in the aviation industry, and it's now a mandate. We do it for every procedure and every surgery. So in ARAVIND, just to understand what we mean by patient safety, about 10 goals are listed, and this is something which makes it easy for our whole team to understand. When we talk about patient safety, what is it we want to focus on? The first goal is to ensure the correct patient and correct eye and procedure. Second goal focuses on having the correct implant power and the correct implant design. The third is to prevent mortality or morbidity, because we are dealing with the older population who are more vulnerable. The fourth would include preventing hospital-acquired infections, including endophthalmitis, including hospital-acquired conjunctivitis. The fifth goal is to eliminate sight-threatening complications. So complications where the patient's final outcome may be very low, could be a glow perforation, could be a expulsive hemorrhage, or a RD following cataract surgery. Eliminate medical diagnostic errors. This becomes very important in the outpatient setting, where we ensure that we are diagnosing the patient correctly and treating appropriately. Ensuring correct medication is critical, as we know, and ensuring correct dispensing of spectacles as well. And ensuring physical safety, again, because patients who come to an eye hospital have poor vision and are the older generation. And to ensure appropriate treatment and follow-up, especially of patients who have low vision or who need immediate care. So while we have these 10 goals, I'll be focusing more on the first, second, and third goal through the course of this talk. So I'll start with 3 case histories. The first was when a patient came into the operating room, and when the patient was being prepared, and the patient was called for surgery, the patient, both the patients had the same name. So when the case records were placed separately, so when the patient was called, the similar named patient but a different patient came, and this was actually identified right before the block because of the correct checking of the case sheet and the medical registration number. But this is not uncommon, especially like I mentioned with our volumes we have in cataract surgery and in eye hospitals. You can have multiple patients with the same name. So using only name, and this is not something which can change overnight. So this is very important to have this as part of the culture, that every member of the team uses a second identifier, most importantly the medical registration number, to ensure we are always treating the correct patient at every step of the process. The second is we actually identified this error in the post-op examination, right after the surgery was done. This patient was brought in from the campsite, and this patient had equal vision of 5/60 in both eyes, and right eye was advised. When the patient came to the base hospital, the advice of surgery was changed to the left eye, because the right eye had a macular scar in the base hospital once the fundus was seen, and advice was changed. However, the wristband was not changed. So in our system, we typically have the patient's wristband tied to the wrist, which corresponds to the eye of surgery. So it was the right eye initially. So the right eye was the wristband remained in the right wrist, whereas the advice was only in the EMR on the left side, and this was not noticed. So based on this, the right eye was marked, and the right eye was blocked, and surgery also happened. And this was seen in the post-op period when the vision did not improve much. The good news is both the eyes, the IOL power was the same. So basically we did not harm the patient much, but otherwise we would have gone wrong if we had not picked this up earlier. So it is again, like I mentioned earlier, it is important to verify at every stage. And if we are changing for any reason, the eye or anything like that, in every aspect of caregiving, not just in your case records, be it your case sheets or your EMR or wristband or marking, at every stage, this has to be corrected, which is what is our protocol following this incident. In the third incident, the patient was advised surgery in the left eye, and everything was done correctly. The wristband was on the left wrist. It was marked appropriately. The eye was marked well. Case sheet, everything was done well. All the workup was done. However, the eye which was blocked was the right eye. This is something which we called as acute failure. And this was actually identified just before the surgery was, and this can again happen because sometimes with the right and left eye confused, like we also see in our clinics, where we see a patient where we want to say right eye, but we advise left eye by mistake, and the counselor may identify and bring it to us. Again, it's very rare, but this can happen because it's a human element. So this is something called as an acute failure, where everything is fine, but once the doctor tries to give the block, they may have this rare incident happen. So to avoid this, we now ensure that we have a second person with the doctor, along with the doctor who's giving the block, to also ensure like we do a timeout before the block. So they also are there, and we also have the instrument set for the subtenon anesthesia on the side where the eye has to be blocked. So having these 2 points introduced in the system has kind of reduced this significantly. We don't have that kind of risk now. So what has been said is that if you kind of follow the universal protocol, the chance of such errors of wrong patient or wrong procedure or wrong site can be reduced by at least 70 to 80%. And what is the universal protocol? This basically has 3 steps. That is to have a pre-procedure verification to confirm the correct patient, procedure, and site, to have the correct site marked always in front of the attender. And this becomes even more important for a child who's going to go under GA, but even for the adult normal patients as well, because many of them may have hard of hearing and they may not be aware which is the correct eye. And to do a timeout mandatorily right before starting the procedure, or be it a block, or be it whatever procedure one is planning to do. So besides the issues with the universal protocol, we may also have upstream errors, like when the wrong eye is advised. That could also cause a wrong site procedure, or a downstream error where everything has been done well, checklist is administered, but right before the IOL is opened, the 2 IOLs are interchanged, and we have the wrong IOL, either power or design, implanted. So, but most important aspect which has been mentioned is to follow the universal protocol. So at ARAVIND, because of the high volume and multiple centers, it became very important for us to ensure we have a very systematic understanding and system in place to prevent this. What started off as trying to create awareness amongst our team also helped us compile these 10 patient safety goals. The culture of reporting, which is the most important and most difficult, because as we all know, behavioral change is very, very difficult. And to create systems, because creating systems can remove a lot of the human errors. Not to say that the individual who is giving the care should not be aware, but that is in addition to the strong systems we have. Use technology wherever possible, like we're using EMR now, so wherever we can have repeat reminders, confirmations, all of that will kind of remove the chance of errors. And if there is a deviation in care, to do a detailed root cause analysis to have a good corrective action and preventive action done, and redesign the system. So based on what preventive action is to be done, then you will kind of modify that. Like I mentioned, if you're having acute failure, we now have a second staff, a sister standing along with the doctor, to ensure the correct eye is being blocked. So you might want to engineer some of the protocols which you have, and constant monitoring, which is, as we know, the most important way to control errors, and reinforcement that we're doing the right thing. So this entire process is important. So I'll just be sharing a video of the flow at ARAVIND as to what we do for our patients. I'd like the audio, please.
Each patient receives an ID card with a unique number specific only to them. This number is required to access the case file, significantly reducing the risk of opening another patient's file by mistake. When advising surgery, a pop-up confirms the eye to be operated on, ensuring the doctor verifies the correct eye twice. Human error in transcription can lead to misinterpretation, thereby causing wrong IOL power or incorrect IOL type being implanted. Hence, we developed a system which is fully automated, wherein the patient's biometry is directly uploaded to their case file in the electronic medical record or EMR. After the patient confirms their lens choice and signs the consent form, they receive an appointment slip to present on the day of the surgery. The list of the next day's patients, including their IOL models and powers, is downloaded from the software by the store staff, who ensures that the inventory has all the necessary IOLs set aside for the next day's surgeries. On the day of the surgery, the patient's case sheet details are verified against their appointment slip and unique ID. Verification is crucial at every step. The eye to be operated on is confirmed with both the patient and their attendant. The ID card is then attached and dilating drops are instilled in the eye to be operated on. After payment, a wristband with the patient and eye details is printed and placed on the wrist corresponding to the surgical site. The details are again verified and a sticker is placed on the site of surgery in the presence of the attendant. The patient is then moved to the daycare room where the perioperative record list and surgical checklist are attached to the case sheet. In the block room, the patient is prepared for the operating room. For surgery under topical anesthesia, the pre-anesthesia checklist is administered here and topical drops are applied. For subtenons anesthesia, the details are verified by both the OR staff and the doctor. The IOL power on the case sheet is confirmed with the A-scan and the pre-anesthesia checklist is administered. The instrument set is kept on the side of the eye to be blocked. The patient is blocked in the presence of an OR staff member to avoid any acute events of wrong side block. The lens is obtained from the store after entering the patient's details and scanning the barcode on the IOL box. Avoid incorrect lens dispensing. After verification, the patient is then moved to the OR. Here, the details are checked against the wristband and a before incision checklist is administered by both the doctor and the assisting staff before the surgery begins. Before opening the IOL, the patient's wristband and case sheet are again verified by the assisting nurse. After the IOL is implanted, the surgery is completed. The post-op checklist is administered just before the patient is shifted out of the OR, ensuring that the surgery is performed on the correct patient, the correct eye, and with the correct IOL.
So that is just to give an idea of the flow. The other aspect, the third goal which I mentioned about, is to prevent significant morbidity or mortality in an eye hospital. For this, we try to ensure we have all the documents collected regarding the systemic condition and the medication. All this is entered and the pre-op workup is done and get the physician's fitness. And for patients who have the details like, like no systemic history or controlled blood sugar and hypertensive patients, they need not be seen by a physician, but they're all monitored, they all have an ECG. For other patients, they are seen by a physician, and most of our tertiary centers have a physician in-house. And secondary centers where we don't have a physician, we request them to get a physician fitness with the format which we give for all the patients. We also have these kind of charts put up, so the patients are aware and our team is also aware. It becomes very clear for communication. And again, during surgery as well, these patients are prioritized. We have another OR staff who's with them to ensure that they are being monitored during surgery and their wait times are not long. So all of this will ensure we reduce the chance of systemic morbidity, and we also kind of very closely assess what is the number of patients who had an emergency. So this is just to list the number of emergencies we had for the year 2024 across all our hospitals. So it is about 4 per 10,000. Some of this were not very significant, but we still would like to ensure in any code blue, anything which happens right in the OT or before or after. By ward we mean either before or after, right after the block. We even have 2 or 3 under topical, and then they have some anaphylaxis to topical anesthesia. So all of this are also collated and monitored, so we know that we are actually taking care of them, and they are made sure that we revive these patients even if they've had a significant emergency. The incident reporting system is very crucial. So right now we have an online portal, but we also started off with just a paper and pen. So we would just ensure that anyone who finds a deviation from the routine, it could include things like a sentinel event or anything with wrong documentation, wrong marking, which did not result in a sentinel event, but a near miss. All of this also are entered, and this is where what make sure that any staff, and this is all anonymous, so this way we would encourage our team to report whatever was not the norm for them. So once sentinel event does happen, it becomes very important to ensure we go down to the depth and understand why it happened. The corrective action and the preventive action is also analyzed in detail. And it's very important to remember that a lot of time we are in denial and say this is a very, very, very rare event. This will not happen. It's like 1 in 10,000 or 2 in 10,000. So should we give this kind of care? But like endophthalmitis, we take so much of effort to prevent one endophthalmitis. So putting the strong systems and ensuring that irrespective of what we follow it is important to prevent these errors. And the training is very important, especially when you have new staff entering. And regular meetings within smaller teams and larger teams are also important while strengthening the incident reporting system. So to conclude, it's important to remember when it comes to sentinel events, our goal is to be 100% right. 99.9% is not good enough, and a comprehensive time out and deployment of checklists and working with the staff to influence their behavior positively are all critical to ensure this happens. Thank you.